Our client is Joe, and at the age of 2, Joe was hospitalized at Johnston Willis Hospital for a fever. According to the father, the physicians administered 3 immunizations to break the fever. Joe's dad noticed that the next day, Joe showed a regression of skills and reported that Joe stopped eating and talking. Joe tended to have a blank stare and was then referred to a developmental pediatrician who diagnosed Joe with autism spectrum disorder. Joe then attended an intensive feeding program for 9 weeks at the Children's Hospital of Richmond, where he began bottle feeding and progressively improved to eating pureed food. Joe's father also reported Joe as having recurrent otitis media, where he underwent surgery for bilateral ventilation tubes. He currently also takes medication to help with his sleep, acid reflux, constipation, and anemia. Joe's father reports that he currently does not self-feed. Joe has also attended Prince Edward School for Early Childhood Special Education program, where he is receiving occupational therapy and speech therapy. It was reported that Joe does not use gestures or single words to request his basic needs or wants or to connect with other people. The school SLP tested Joe for his auditory and receptive abilities using the PLS-4. His scores were 51 for auditory comprehension and 50 for expressive comprehension. The SLP also noted that Joe's expressive abilities were limited to spontaneously producing M and K sounds and no imitations. Joe's present level of academic achievement and functional performance summary reports that Joe shows that he understands the command no, which is conveyed verbally as well as through sign. Richmond's Children's Hospital reported that in situations where Joe becomes upset, for example, someone takes his toys, he positively responds to a strong embrace and rocking motion, which helps calm him down. Through informal assessments, Joe limited himself to solitary play with limited imitation skills. He did not demonstrate turn-taking, and he played with only 1 or 2 objects. Joe also demonstrated some sensory issues through testing. It was noted that he needs to keep his hands clean at all times and that he dislikes textures that are gooey or solid like dirt. He also dislikes the sound of a blender and struggles to adjust to changes in his daily schedule. As for the diagnostic criteria, Joe displays characteristics of the following DSM-5 criterion: A1 through 3, B1 through 4, C, and D. For example, in A1, Joe would take the toy from the adult, but often did not interact with the adult, and throughout play with other children, he participated in only solitary play. For A2, his father stated that he often had to guess what his child's intentions were when he was using signs and gestures, and he often did not use eye contact. And also, for criteria B1, he would often engage in play by spinning toys or only manipulating parts of the toy, like spinning the wheels of a car. He was also seen to be unlikely to play appropriately with other objects or played with very limited toys. The functional outcomes selected for Joe will help him to develop a communication system, to develop a clear and unambiguous message, as well as enable him to develop the ability to initiate and engage in joint attention with others. The information derived from previous assessments indicate that Joe does not engage in communication with others at a level that would be typical for children his age, and he also displays problematic behaviors.
According to Duran 1990 and Duran and Meggs 2008 and 2009, functional communication training, FCT, is a technique used to replace the problem behavior with an alternate behavior. Functional communication training occurs in a 7-step process. The first step is to assess the function of the behavior. The clinician should first identify the behavior and the purpose for that behavior. Through assessment tools, these behaviors can be identified, and the variables that keep maintaining those behaviors can also be identified. The second step is to select the communication modality. For example, if the client uses sign, then the clinician should continue to target the desired behavior in sign. The type of communication modality is chosen based off the client's ease to learn the appropriate behavior. The third step is to create teaching situations. The clinician should begin to set up the environment in a way that creates opportunities for the client to demonstrate the problem behavior to use as teachable moments for the alternate behaviors. These training trials are important for the client to learn that intended response. The fourth step is to prompt communication. During this stage, a multi-phase prompting procedure is used, then faded as quickly as possible. For example, the clinician could first teach the sign for help, then move on to having the client request for assistance independently. The fifth step is fading of prompts. Prompts can go from full physical prompts, partial prompts, which is touching of the hand, gestural prompts, and finally, a verbal prompt. During this stage, delayed prompting is also used to help with fading prompts. For example, the clinician could wait 5 seconds to see if the client responds before prompting again. By waiting for the prompt, the clinician sees that the client can move on to the more simple prompt in the future. The sixth step involves teaching new communicative responses. During the stage, requests for food, music, work, etc. are expanded along with the settings that these behaviors occur in as well. The final step, step 7, is modifying the environment. During this stage, the clinician begins to work on environments that are more functional for the individual. For example, if in the session behaviors are no longer occurring, the clinician should move on to an activity in which the behavior is more presented, such as during certain instructional programs or in front of certain staff. At this time, expanding outside of the clinical setting should be used, such as home and school environments that are more natural. Based on the intervention procedure, we have chosen the first short-term objective for this session. We have chosen the objective based on Joe's need to build his early functional communication skills, which include requesting for actions and objects. In Joe's case study, it states that Joe struggles to use gestures or words to communicate his needs. He uses limited signs and when frustrated tends to lash out with inappropriate behaviors. By first addressing Joe's immediate early functional skills, we are beginning to build more advanced communicational interactions for the future. This objective aligns with intervention because it helps with creating a standard functional communication base for future interactions with others, and it decreases behaviors that occur due to a lack of communication. It addresses his functional outcome because it helps him begin to build a clear message to communicate his wants with others. By targeting this session objective, we are also working towards Joe's long-term goals of using early functional communication intents for over 8 minutes. By targeting this objective first, we begin to increase his communicational intents. At this age, Joe's currently not using 7.5 intents per minute, which is not typical for his age.
The functional outcome for Joe's treatment plan is to be able to communicate wants and needs to send a clear, unambiguous message to communicate. For this session, we are targeting the first long-term goal, which is for Joe to independently use a symbolic communication system with familiar adults to request objects and/or actions an average of 8 times for every minute of a structured activity during a 30-minute session. The short-term objective chosen was 1A, which is for Joe to use a symbolic communication system with familiar adults to request objects and/or actions an average of 3 times for every minute of a structured activity during a 30-minute session with no more than 3 gestural cues. Based off the short-term objective, we have chosen to target Joe's behaviors to request for objects and/or actions as the first session objective.
According to the American Psychological Association standards, FCT is an established intervention. An established intervention indicates that there is sufficient evidence that the intervention leads to positive outcomes. There is extensive research in the use of FCT across various populations to treat and reduce challenging behavior by using a communication system as the replacement behavior. Research suggests that the approach is efficient when the reinforcer is more desirable than the problem behavior. A study by Horner and Day in 1991 thoroughly examined FCT with a client who displayed aggressive behavior when he wanted a break from an activity. The researchers taught the client to sign break, which significantly reduced his behaviors and increased his participation in activities. This is applicable to Joe because he frequently displays problem behaviors during activities. By applying FCT, Joe will use a functional communication system to send a clear and unambiguous message in place of the problem behavior. Research also suggests that this intervention strategy is successful in individuals ages 3 through 21 years. At the age of 4 years old, Joe is within the range for this intervention. In addition to establishing replacement behaviors, there is research by Carlson, Luiselli, Slyman, and Markowski in 2008 that FCT is successful when choice making is available to the client across daily activities. This is essential research because the clinicians will include the caregivers into the session to encourage application of FCT throughout the day. According to the research, only the desired behavior should be reinforced. Shirley et al. In 1997 studied the efficacy of this continued reinforcement for challenging behavior. The study found that negative behaviors were not initially reduced when they were reinforced with the new communication method. However, when only the communication was reinforced, the negative behaviors were eliminated. This is another aspect that the clinicians will implement during the session and teach the caregivers. Additionally, according to research by Durand and Mergis 2009, FCT is successful in teaching forms of communication that is acceptable to others, which supports generalization to other settings. Overall, all of the research supporting FCT state that the goal of FCT is to make the new communicative response more effective at getting a response than the undesirable behavior.
The therapy session will take place at Longwood Speech, Hearing, and Learning Services Clinic. Joe is already in therapy at School for Speech, so we want to provide him with therapy that is within a clinical setting. The session will be in a therapy room with Joe, the speech-language pathologist, and a caregiver who are interacting throughout the session. The functional outcome for Joe's treatment plan is to be able to communicate wants and needs to send a clear, unambiguous message to communicate. For this session, we are targeting Joe's first short-term objective. Joe will use a symbolic communication system with familiar adults to request objects or actions on average of 3 times for every minute of a structured activity during a 30-minute session with no more than 3 gestural cues. The structured activity will consist of Joe having the option to play with different toys that are of interest to him. Before he starts playing with one toy, he must use his symbolic communication system to make his request. The different toys that will be available to Joe will include toys in which he likes and is most familiar in order to facilitate the most natural environment and interactions with Joe. Such toys will include blocks, a variety of wind-up toys, as well as the spinning objects, as these were reported as likable toys throughout his case history. Additionally, since Joe's case history stated that he did well at mealtime when a Beyoncé song was played, different Beyoncé action or doll figures will also be available, in which he will have to request to be able to play with them. During FCT training, it is important to address these interests because Step 3 addresses using teachable moments. The SLP will also provide prompts when appropriate and try to keep Joe focused on the activity at hand. The caregiver will be actively participating in the activity with Joe and the SLP. Additionally, the SLP will provide the caregiver with different strategies, techniques, and/or prompts that he or she can use when Joe is at home. In this next section, we will demonstrate a portion of Joe's treatment session using the FCT model. Katie will be acting as Joe's mother, Molly will be acting as Joe, the client, and Sheridan will be acting as the speech-language pathologist.
Hi, I'm Sheridan.
Hi, Katie.
Nice to meet you.
Nice to meet you.
So I'm the SLP here, or speech language pathologist, in our clinic. It's Speech, Hearing, and Learning Services at Longwood. So we're just going to work with Joe. I'm going to tell you a little bit about what we're focusing on, and then how you can implement that at home and help him with implementing it at school. Okay? So something that we're going to focus on with Joe, it's called functional communication training. We call it FCT for short. So it's where we implement a technique that's used to replace a behavior. So sometimes he has outbursts or tantrums, so we want to find an alternate behavior when he has those feelings. So it's a 7-step process. Right now we're on the 3rd step. So the first step that we've already done, we just assess the function of his behavior. We've already done that through our evaluation, and then we can move to the second step, which we did, which is selecting the different types of communication modalities, which is just different ways we can communicate. You know, we're using words, you can use sign language. We have this picture board, which is where he can point to things to show us his wants or needs or a request for objects or actions. So we've already done step 2. And then the third step is creating teaching situations. So we want to put Joe in a natural environment where he'll most likely be, like at home, or where this can be implemented at school. And I'm just going to get started a little, and I'll show you kind of how we can use gestures and help him. So then I'll have you try it before you guys go home today.
Sounds good.
All right. Hi, Joe. All right, so can I have the toy, please? We're going to be using our communication board, so hand me the toy. Thank you. All right, so we have all the different things that you can choose from. And if you need a break, you can just point to the break. But what you have to do is point, and that's how I'll know. So what one would you like to play with? So we're going to use this. Let me show you. If you want blocks, you try. There you go. So, Mom, you see how he's not going to get what he wants until he does the right gesture for that.
Gotcha. Yeah.
Nice, Joe. Thanks for pointing to what you want. And if you want another block, remember what we can do? There you go. Cool. And it's as simple as using a gesture where we just point. You don't have to say anything.
Okay.
All right, Joe, do you want to play with something else? If you want to, remember, you can point to what you want. So I'm going to have you try to do this. You can just kind of hold it from him and redirect him by pointing.
Okay. Ready? We're gonna point. We're gonna point. You're so strong. We're gonna point.
There you go.
go.
Good job.
Do you need help? Do you need help? You need help? Okay, ready? There you go.
So we chose, that was something that we chose, so it's kind of like in Beyonce, we know he likes Beyonce. We chose that because it's kind of a communication temptation where he just doesn't get the doll. He has to request for your help to open that jar.
Okay.
So we don't want it to be just pointing, but
That's good. That happens a lot during the day.
Oh,
Where I
it
tell he
does?
wants something, but he can't really tell me.
okay. And now you can redirect him to it when take us home and implement it at home.
Okay.
Joe, would you like to play with something else? And if you need help, you can ask me for help to close the jar.
Hey Joe, let's pick another activity. Ready? Do you want Play-Doh or blocks? Do you want Play-Doh or blocks?
Awesome, Play-Doh.
Play-Doh!
Yeah, Joe, you're doing a great job. And if this happens at home and you think he's getting frustrated or kind of bored or tired, and you see those behaviors that you've seen, the tantrums and outbursts, you just redirect him here. If he wants a break, then he gets it if he points.
Okay.
Cool, Joe. Are you stacking the Play-Doh? Oh, we're playing blocks and Play-Doh. You're doing a great job playing. How do you feel about everything, Mom? Are you comfortable to implement this?
Good, yeah.
And
I definitely think I can.
Good.
Should I start to add words with the pictures?
You can maybe down the road. So the speech pathologist at the school and then here will work towards that.
Okay.
So right now we can just kind of start with so many gestures a minute. We're aiming for around 3, no more than 3 a minute. And maybe we can work up and decrease that and then maybe move to verbal or using words.
Okay, cool.